Hi, my name is Dr. Dashti, and this is Dr. Tom Yao, my partner. We are co-directors of cerebrovascular neurosurgery at Norton Healthcare at the Norton Neuroscience Institute, and we're doing this Facebook Live post on pseudotumor cerebri, or idiopathic intracranial hypertension. It's a disease that affects a lot of people in this country, and it's kind of poorly understood and somewhat difficult to treat, and we want to shed light on this disease and the treatment options available. I'm going to give it to my partner, Dr. Yao, to talk about the symptoms of pseudotumor cerebri in a second, but basically what pseudotumor cerebri is, it has the word tumor in it, but there's not actually a brain tumor. It has symptoms that you would associate with something being in the brain, like a brain tumor, but there is no brain tumor. There's increased pressure in the head. No one knows what causes this increased pressure to occur, but there's increased pressure in the head, which causes the symptoms that we'll talk about, including headache and vision problems. It happens most often in young women, although it can happen in men, much more rarely, but most of the time it happens in young women, and it happens more often in overweight individuals. And again, we don't understand really the reason behind that. But I'll refer to Dr. Yao to talk about the symptoms, and then we'll talk about the treatment options.
Yeah, so this is another thing about the name of this disease is often they call it benign idiopathic intracranial hypertension. Just because the word benign is in there, it's not benign because it puts your vision at risk. So that's one of the key symptoms. It often has headaches, and if you look over here, headaches behind the eyes, worsen with movements. These aren't definitive, it's just a whole combination of things, and most people have some of these, all of them or some of them. Blurred, dimmed vision, and that's the key. Once you're having those symptoms, that becomes serious. Brief episodes of blindness in one or both eyes, difficulty with peripheral vision, double vision, flashing lights, ringing in the ears, nausea, vomiting, or dizziness, and just some vague neck, shoulder, back pain. A lot of these symptoms it's important to realize that not all of these symptoms, if you have these, you have pseudotumor cerebri. These symptoms are general, and the diagnosis of pseudotumor cerebri can mimic many other disease processes overall, and so it's important that just because you're having these symptoms doesn't mean that's what you have. And that's critical, because obviously if you're misdiagnosed and you're treated one way, then if it's not pseudotumor or pseudotumor that is caused by this process, you're not going to get better with any surgery. So that's important to realize. It just means that maybe you need some sort of doctor evaluation or neurologic evaluation so that we can rule things out and hopefully make things better.
So basically, with pseudotumor cerebri, the main thing is the pressure inside the head of that individual patient is very high, higher than it should be. What causes that to begin with? No one knows. We don't know what precipitates the disease process, but we know that it happens. The way to diagnose it is really the symptoms. The patient gets medical attention by their doctor, usually orders a MRI to make sure there's not another process like a brain tumor or something else causing increased pressure. Once that's ruled out, then the next step is a lumbar puncture, where they put a needle in the back, draw off spinal fluid to measure the pressure of the spinal fluid, which is a proxy measurement of the intracranial pressure. If that pressure is elevated, then that points more towards a pseudotumor diagnosis. Now, this is like I said, no one knows really what the baseline etiology of this disease or the cause of this disease is. It's probably heterogeneous. Probably many different things lead to this disease constellation. But we're going to talk about now what can be done for it. All right. Once the patient is diagnosed with pseudotumor, first of all, why should anything be done? Number one, the headaches are debilitating. And people are miserable with these headaches for years and years. Second, and more importantly, is what Dr. Yao alluded to, is the possibility of vision loss. We have seen young people, not always obviously, in some cases where the disease is very progressive, they can lose significant vision and even become blind in both eyes. That's the result we want to prevent in pseudotumor patients. And really the only medication that's available is acetazolamide or Diamox. It's a type of diuretic, and it works somewhat. It's not a great medication, but it's the only one that really works, and it has a lot of side effects. A lot of people don't tolerate it. Outside of that, the options are shunting, where you shunt the spinal fluid from the brain into the belly, which involves an operation and implanting a foreign shunt material in there. That works well to decrease the pressure. The second option is optic nerve fenestration by an ophthalmologist, which they do a special surgery to poke holes in the back of the eye to relieve some of the pressure on that optic nerve to prevent that blindness from happening or vision loss. And the third option we're going to focus on is a much more modern or newer option. It's endovascular treatment of one of the underlying causes of pseudotumor, and that's venous sinus stenting. In a certain high percentage of patients with pseudotumor, not 100%, but a high percentage of them, majority of them, we think that one of the major causes of the pseudotumor cerebri is the venous blood backing up in the brain. It's not draining out of the brain like it normally should, because the heart pumps the blood, goes through arteries to get to the brain to carry oxygen and nutrients, and then it has to come back through the veins back to the heart and do the whole process over again. It doesn't work well when you pump it up there and then it can't get out. It gets backed up, and that causes venous hypertension. The pressure in the veins goes up, spinal fluid can't get reabsorbed, and that builds up, and we think that's the etiology of the increased intracranial pressure in a large majority of pseudotumor patients. Over the last 12, 15 years in the endovascular neurosurgery community, we've had a lot of experience with stenting of individuals with pseudotumor that have narrowing of the major veins of the brain that can cause that backup of blood that I just talked about. And if the patients are selected properly, the results are very, very good. More than 90% of them will have complete resolution of their symptoms. And we'll show some videos of that as well.
So it's important to realize that when we talk about this disease process, the treatment that we're showing today is successful in a particular type of pseudotumor. There's many different causes and things like that. That's why it's important to select out exactly what is the cause, and that requires doctor evaluation. But if you don't realize that this is even an option, then if you're living with something that could potentially ruin your vision, you want to be sure to have it checked out. Otherwise, that's the main thing that this treatment does. It protects your eyes. It doesn't always affect headaches. It does a lot of times, but really it's protection of your eyes, because seeing is so important.
And some patients, they do fine on Diamox, the medical treatment, and they can stay on it for years if they tolerate it and they have good relief and they're stable, and that's how they get managed. If the Diamox doesn't work, which a lot of times it doesn't work well enough, or they have a lot of side effects, then the next option is some kind of more invasive treatment, right? We talked about the optic nerve fenestration and VP shunting of the spinal fluid, which are good procedures when the vision is at risk, and help mitigate that. The endovascular option, where we go from inside the patient's vessels, the veins, and go up inside the veins of the brain and stent open that narrowing, that is the kind of the root cause of a lot of these pseudotumor patients. Not all, a good percentage of them. That's a more modern treatment. It's not available in most places, but it's the more modern treatment, and it's really a much more elegant solution to a very difficult problem, kind of trying to treat it at the very root cause. Obviously, not everyone qualifies for that. We get an MRV looking at the veins of the brain, a special scan, MRV or CTV, looking at the veins of the brain and see if they have that narrowing. For some reason, pseudotumor patients will have this narrowing at the sigmoid and transverse sinus junctions, the major veins of the brain, always at the same spot. For whatever reason, increased pressure causes narrowing of the veins in that same spot. If they have that on the MRV or CTV, then we go ahead and take them to angiography. We go in there and confirm that the narrowing is there, and then measure the pressure, make sure there's a pressure gradient difference across that narrowing, and if there is, those are the patients that benefit from stenting. And this is what I'm showing here. If you look up here, on the left is on the top is the narrowing of the sinus. You can see thickness, kind of narrowing, and then thickness again. That's where the typical narrowing is in a transverse sigmoid junction, sinus junction. And here on the bottom, you can see the same patient after stenting. You can see the flow of the venous flow out of the patient's brain is much better. The sinus stenosis has been opened up by the stent, and typically patients that have this appearance will have a significant improvement in their symptoms. The pressure inside their head normalizes, and then there's no need to worry about vision loss. and you can take them off their medications as well. It works in more than 90% of the patients, but not 100%. The procedure, you want to tell them about where the procedure is done?
The procedure has to be done in a special operating room in which there's a biplane fluoroscopy. So it has specialized X-ray. So it's much more than a cardiac cath lab, but the procedure itself is very similar to a cardiac cath. Typically, we watch patients overnight in the ICU and everything going well, patients go home the next day. Because there's a stent, we actually treat patients with aspirin and Plavix before the procedure and after the procedure as well.
And up here you can see the view of the control room. This is the control room for the biplane angio suite. This is our endovascular team doing the stent procedure. You can see this is that same patient that I just showed where we stented the sinus. This is actually the stenting procedure. Here you have a guide catheter in the sigmoid sinus on the right. This stent comes up. Here's the top end of the stent, the bottom end of the stent. And I'll show you as the stent comes out and gets unsheathed and placed across the stenosis. There you go. You can see the stent coming out. And that's basically it. And that's us, Dr. Yao and myself, working along with our team. And you can see here's the run right after the procedure. You can see here's the stent, and you can see much better flow in that vein. So we took what was the narrowing, which we think in this patient and in the majority of patients is the cause, one of the root causes of the patient's pseudotumor, and reopened it, allowing the blood flow to drain normally out of the brain, which allows the venous hypertension to be resolved and the increased pressure in the head to be resolved. Now, we have a question from the audience. The question is, why is this pseudotumor more common in women? And why don't you answer that, Dr. Yao?
Well, it's mainly because we don't know. It just happens that way. Is it hormonal? Who knows? Maybe their body mass distribution is different than men. You know, there are gender differences and that type of thing, body type, all that kind of stuff, but nothing's...
Bottom line is no one knows why, right? It obviously has something to do with our different physiologies and anatomies, but we don't know. Another question is, what is the stent made out of? The stent is made out of a metal alloy, similar type of alloy that people that have heart stents in the coronary arteries or carotid stents, similar type of metal, different metal alloys that allow the stent to have a kind of a springy ability to be able to have radial force and expand outwards and keep this vein open. It's a permanent implant. It doesn't come out. It becomes part of your vessel wall. The vessel kind of grows over it. It's an inert material, so it's well tolerated. People usually don't have a reaction to it. And it's, from our experience, which is pretty extensive, there's not really a lot of concern for the stents clotting off because it's placed inside a very large vessel. And as long as they do the aspirin Plavix that Dr. Yao talked about for a few months, I think we have a very high patency rate as far as risk of clotting is very low.
No trouble with MRIs or anything like that. It's very small. And if you think of it, it's like a chicken wire tube that just kind of opens up. That's what that is.
Another question from the audience is, what are the risks of the procedure? Well, because this is done inside the major veins of the brain, the venous sinuses of the brain, it's all done through the leg with a catheter, but we do fish it up all the way into the veins of the brain. If something goes wrong, it can be serious. Bleeding or stroke can happen, which can cause death, coma, paralysis, anything you can think of, but that risk is pretty low. It's much less than 5%, but it's not zero. So there is definitely some risk of serious complications anytime we do a major procedure in the brain. But obviously, we take that risk for a patient when we think the benefits outweigh the risk. What are the benefits? Someone whose vision is at risk, their risk of going blind or losing significant peripheral vision, I think that's a risk worth taking. Now, is it a risk worth taking for debilitating headaches? That's a question I don't have an answer for. But as far as preventing vision loss, I think it's a very high yield, low risk procedure, but not zero risk.
And that's why you have to really consider all the options and get all the evaluations, because you are taking a risk, and if you don't have a very good chance of having this help you, there's really no reason to take the risk. But otherwise, yes, if you fit the criteria and you are a good candidate, of course, if you can save your vision, you know, if you do nothing, you're just going to go blind.
And the last question is, what if it doesn't work? It's possible it may not work. Like I said, if selected properly, looking at the MRV, making sure the patient has a narrowing in the vein and confirming it with angiography, measuring pressures, and then stenting, more than 90% of the time, people will have a benefit. It resolves their pseudotumor symptoms, protects their vision, majority of the time makes their headaches go away or get significantly better. But does it work 100% of the time? It does not. It does not work 100% of the time. And in cases where people had this procedure and they're part of the 10% of people that they do not have resolution of their symptoms, and we don't know why that is, then the only other options left are the other things we talked about: optic nerve fenestration or VP shunting, which are, you know, additional types of procedures, surgeries, but those are available as a backup option.
And also universally, it's important that we mention this as well. One of the best ways to deal with this, actually, it's a indication for gastric bypass. We've had many patients who lose the weight and these symptoms just disappear, and they do very, very well. And really, it's the net issue oftentimes is the weight. You lose the weight and you do get better.
But I've been trying to lose 5 pounds for the last 5 years. It hasn't worked. So it's easier said than done.
Yeah.
But that's why if everyone could lose 50 pounds, it would be actually very beneficial. We wouldn't have to do a lot of these treatments. But it's very difficult for a lot of people to do that. Now, please submit any more questions that you have, and we will answer them after this post. And thank you very much for joining us. Do you have any other comments, Dr. Yao?
Thank you very much.
All right, thank you.